Okay, so today we're going to be talking about aneurysms. And here on the first page, you just see a visual of thoracic and aortic aneurysms versus abdominal aortic aneurysms. And this one's green because it matches the picture right here, which is a picture of your chest and an aneurysm in your chest. And this one is blue because cyanosis is one of the hallmark signs of abdominal aortic aneurysms, and whenever I think cyanosis, I think blue. Okay? Alright, so something to keep in mind is that usually these people, regardless of whether they have TAA or AAA, it's going to be usually is asymptomatic, and these patients usually discover that they have an aneurysm when they come in for some unrelated illness or disease or scan, like an ultrasound scan of some kind. Okay, and then they're like, oh, you have an aneurysm in there too. Okay? So, let's start off with TAA. In other words, thoracic or chest aortic aneurysms. Basically, what I want you to get out of this this section about TAAs is that it's edema from the neck up. They're going to have a cough and they're going to have chest pain. Okay? Now let's go into detail. 85% is caused by atherosclerosis, and these are the chest problems that they're going to have. They're going to have chest pain, and it's a prominent symptom, some kind of angina, and that's chest problems that they can have. With regards to neck problems, they can have dyspnea, stridor, or dysphagia, making it hard to swallow. And the reason for that is because there's pressure on the trachea and they're getting choked. See here? And that will cause a cough because it's also putting pressure on your laryngeal nerve. It's tickling your throat. Okay? And if the patient's coughing a lot, then eventually what they're going to get is hoarseness, and they can even lose their voice from coughing so much. And visually, what you're going to be seeing is distended neck veins, edema of the head and arms, cyanosis, and you might think, why? Why are they having these signs and symptoms? And that's because there's pressure on the superior vena cava, and that's decreasing the venous return. And another thing they can have is unequal pupils. And why is that, you may ask? It's because there's pressure on the cervical nerves. Okay, and here's some visuals on what the patient's going to look like when they come in, when they do display symptoms. They're going to have the distended neck vein, as you can see on this woman right here. They're going to have edema of the head and arms. So they're going to come in with a really puffy face. And this is just a visual of the nerves in the cervical region. Could be affected by the aneurysm in the chest. And of course, that would lead to the coughing, which would eventually lead to the hoarseness and the loss of voice. And it could also lead to the unequal pupils because of that same nerve problem. Now let's move on to abdominal aortic aneurysms. Basically, what I want you to take out of this section is that you're going to be getting cyanosis from the belly down. Okay, so cyanosis of the feet, the toes, things like that. And you're going to be feeling and hearing a heartbeat in the belly. As you can see here in this picture, the heartbeat is in the belly, and that's because the aneurysm is in the belly. Okay, so they're also going to get some belly or back pain. That's because, again, it's in the belly, and the pain can radiate towards the back. 60% are asymptomatic, as we discussed earlier. They may report a feeling of a heartbeat in the abdomen when laying down. They may complain of an abdominal mass or a throbbing pain in the abdomen or lower back, as we said earlier. And back pain means that the aneurysm is pressing on the lumbar nerves. And the pulsatile mass may be palpated. So, as the nurse, if you palpate the abdomen, you're gonna feel that that pulse right there. And if you auscultate the abdomen, you can hear the what's called a bruit, which is a whooshing sound. Okay. And this may mimic pain associated with abdominal or back disorders. They're also going to have ischemia of the limb or the toes, and that can come off as mottling, which you can see here, the little blotches of purple, and cyanosis, which would be being blue. And that can be the first sign of an AAA, an abdominal aortic aneurysm. And the reason that the patient gets these symptoms is because this aneurysm, some of the atherosclerosis, some of the blood clots can dislodge and it can travel downwards to the legs. And that's why uh, you can have these symptoms from the belly down. So they can get it in their legs, in their feet, or just in the toes. If it's a really small clot that got stuck in like the toes, okay? And here is a visual that we're gonna go into later down the road. Basically, what you need to take out of this is that Um, the aneurysm needs to be 5.5 to operate on, and we're just going to go into more depth about these things later on in the lecture, but I just wanted to touch base on these while we're here. These kidneys right here, this kidney is flicking a cigarette because smoking puts you at risk for abdominal aortic aneurysms, because smoking increases your blood pressure, and increased blood pressure puts you at risk for abdominal aortic aneurysms. And the most common cause is atherosclerosis, which is why this artery is this aorta is so full of plaque. You see, it's even spitting stuff out from here. And he's like, call the surgeon. And he's handing this old man the phone because his aneurysm is greater than 5.5 centimeters. And whenever the aneurysm is greater than 5.5 centimeters, then that's when you need to do the surgery. And so the reason they have this old man here is because older Caucasian males are at greater risk for these aneurysms. And you can see that as well. All right, let's move on to the lecture. Here's some videos that you can watch. The first two are from Nucleus Media. They make excellent animations on basically the patho behind it and just a brief overview of the condition itself. And these last two are videos made by RNs on YouTube that go into further detail about what you as the nurse are responsible for. Here's some nice to know things that we can just skim over. Um, they're nice to know, but they're not things that are going to be tested on. So basically, this tells you what an aneurysm is. It's a sac or a dilation, as you can see in this picture right here. And it occurs more often in men than women, as we discussed earlier and as we saw in that little comic that we just went over. And the incidence increases with age. It's classified by its shape or form, but the most common ones are this one, the saccular one, because it looks like a little sac right there on the side of the blood vessel, and fusiform, which looks like this. All right, so there's different classifications of aneurysms, and these are the notes that the professor took, which are way better than what the book mentioned, because the book just went into way too much detail. Look at all this. So basically, what the professor wants you to take out of all of that, that was in the book, was that basically anything that leads to degenerative changes to the medial layer of the aorta is going to cause this problem of aneurysms. Basically, whatever wears down the layers of your blood vessel, your major blood vessel, is going to put you at risk for this, uh, uh, at risk for aneurysms. Another thing that could put you at risk for it is congenital, family tendencies related to abnormalities, atherosclerosis, as we highlighted earlier and touched base on earlier. As we saw in the little comic, the little blood vessel was full of so much plaque and so much plaque was just all over that blood vessel, okay? And mechanical, like penetrating or blunt trauma. And here you can see a little picture of that. This guy is getting punched in the abdomen, and that could lead to an aneurysm. All right, and this is basically what the book said, but we're just gonna skim through that and skip it because it's way too much detail. And here's a little picture about my feelings towards that. I'm like, what did you say? All I heard was blah, 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 because this is just way too much info than you really need to know. All right, let's go into what you really need to know. Thoracic aortic aneurysms, TAA. Okay, as we discussed earlier in the picture, most are caused by atherosclerosis. It happens more often in men than women, and the incidence is going to increase with age. Dissecting aneurysms commonly occur in the thoracic area as well, but that's like more so of a side note. Okay, and in comparison, aneurysms in general mostly occur in the abdomen. Okay, this is just a compare and contrast because you really need to know the differences between the thoracic aortic aneurysms and the abdominal aortic aneurysms, and I want you to keep that in mind while we're going through this. I want you to be comparing and contrasting with uh, with the opposite aneurysm when we're going through this. So just keep that in mind. This one, okay, so 1/3 die of rupture of the aneurysm, and that's because it's so close to the heart. And this is going to lead to basically everything around your body. This is the main blood vessel. Okay, it's a really really big blood vessel. Okay, so these kinds of things are really deadly. Clinical manifestations, as we said earlier, there's going to be edema from the neck up, cough, and chest pain. And we already went through this. So we can just skim through this again. See? Here's the pictures again. Alright. With regards to abdominal aortic aneurysms, here's the picture again to remind you of what we went over earlier. And this is going into details about it. Okay, abdominal aortic aneurysms are the most common aneurysms, as I said earlier, when I was comparing and contrasting with the thoracic one. Okay, so this one, the abdominal one, is the more common one. And again, common cause is atherosclerosis. As we can see here, this blood vessel is covered with all this plaque. Risk factors are age greater than 50, Caucasians, and males. As you can see, this guy is a male, he's Caucasian, and he's greater than 50 years old. Men are 3 times more likely than females to suffer from aneurysms. And also a risk factor is family history and tobacco use. This is a major risk factor, okay? In fact, when we do discover that they have aneurysms and it is smaller than 5.5, we usually tell them to stop smoking because that's going to increase your blood pressure and increase your risk for that aneurysm to rupture. So I just really wanted to emphasize on that, and I want you to memorize this. Another thing is hypertension, and anything that would cause the hypertension, like the smoking that we mentioned, would increase your risk for aneurysms. And it can be associated with aneurysms in other arteries. The growth rate is unpredictable. The larger the aneurysm, the greater the risk of the rupture. And here are some extra notes that I wrote while we were in lecture. The aorta is the largest artery, which is why when it ruptures, it's so deadly. And it's responsible for supplying oxygenated blood to essentially all vital organs, which is why a lot of people die from this if it ruptures. Okay, so clinical manifestations. Um, if you remember when we discussed on page 1 that, basically what you need to remember is cyanosis from the belly down, feeling and hearing the heartbeat in the belly and back pain. And that makes sense because this is an abdominal aortic aneurysm. Okay? So, again, 60% are asymptomatic. They may report feeling a heartbeat in their abdomen when they're lying down. They may complain of abdominal mass or throbbing pain in the abdomen or lower back. Back pain means the aneurysm is pressing on the lumbar nerves. And this is important, and I really want you to memorize this because this is a telltale sign of an abdominal or aneurysm that you as the nurse assess. So when you're palpating the abdomen, you can feel it pulse. You can feel the pulsating mass, okay? And when you auscultate the abdomen, you will hear a whooshing sound, which is known as bruit, okay? Memorize that because that's a possible question. It may mimic pain associated with abdominal pain or abdominal or back disorders. It's frequently detected on physical exam or when the patient is examined for unrelated problems, and that's because it's a lot of the times they're asymptomatic. For example, when they come in for a CT scan or an abdominal x-ray. Okay, so dilated aortic wall could form a thrombi that can embolize, and the emboli can lead to ischemia of the limb or the toes. And some signs and symptoms would be mottling, which you can see in this picture right here, and cyanosis, as we discussed before. And this is important to remember because they can be the first signs of an abdominal aortic aneurysm. So whenever you see cyanosis or ischemia from the abdomen down, and you you feel the pulsating mass and you hear the bruit, then or the whooshing sound, then you need to automatically think, okay, this is an abdominal aortic aneurysm. The emboli can also go to the kidneys. They can be passed there, but most abdominal aortic aneurysms are below the renal artery, which is also known as infrarenal aneurysms. Thrombi can also form when abdominal aortic aneurysms press on other vessels and cause stasis of the blood in those vessels, like the inferior vena cava. Okay. All right. Now let's look at both TAA and AAA. All right. So complications for both of these, you're concerned with a rupture. That's a serious complication related to an untreated aneurysm. With AAA, the rupture can go into the peritoneal cavity or into the retroperitoneal space. This person with this abdominal aneurysm is going to have severe pain that can go and that can radiate to the back or the flank. They can have flank ecchymosis, or they can have back ecchymosis. If it's undetected and it ruptures, then 80% of the people are going to die before they even get to the hospital, because that's just going to lead to some massive hemorrhaging. And if they are in the hospital, then you would see a decrease in blood pressure, a decrease in hematocrit and hemoglobin, and these are telltale signs that of a ruptured aneurysm. So you really need to pay attention to this, because this is a life-threatening condition, and if it ruptures, this person is going to immediately need a life-saving intervention, like life-saving surgery. So you would immediately report this to the doctor. You as the nurse are responsible for knowing this, as in this would be a wonderful test question. So just to emphasize on how deadly this disease is, this condition is, I wanted you to know that most do not survive long enough to get to the hospital. Diagnostic studies, you're not really going to be tested on this. You're more so going to be tested on your nursing interventions. But I just wanted you to get exposed to this. X-rays, the chest demonstrates where it is, how wide it is. In the abdomen, it might show calcification. ECGs are to rule out MI, myocardial infarction. Okay, and some other diagnostic studies. Basically, they're all going to show you the aneurysm. Okay, so for management, goal is to prevent the aneurysm from rupturing. That's the main goal here. Once it's detected, studies are done to determine the size and the location. And we're going to go into why in just a moment. You need to get this patient on blood pressure control, pain control, and close monitoring of the symptoms. You need to do some risk, and that's if they choose not to do surgery. You need to do some risk factor modifications, tell them to stop smoking, and to basically decrease their blood pressure. Now let's move into surgical interventions. To do surgery on this patient, that aneurysm needs to be at least 5.5 centimeters wide, aka 2 inches wide. That's the threshold for you to go in there and start tinkering around in that person's abdomen or chest, okay? Because these are some major surgeries, and you don't want to do this for some small little aneurysm, because let's say a 30-year-old patient comes in, and they come in for a regular ultrasound or whatever, and the doctor is like, oh, you have an aneurysm. Okay, we're going to put this patient on some blood pressure meds and some tell them to stop smoking if the aneurysm is less than 5.5, and that patient can go and live the rest of his life, like 70 more years, and never have any more problems with that aneurysm. That aneurysm could last him 70 years. It would not rupture. Okay, so that's why you gotta weigh the pros and the cons, because if you do choose to do surgery, then you're gonna be tinkering around inside this person's chest, and that's really dangerous. Okay, it comes with its own risk factors, which is why we set up these thresholds for when we perform surgery. We only perform it when it's too big. Okay? All right. So if it's not that big, then we wait. We just we just do some watchful waiting if it's less than this size, with some ultrasound follow-ups every 6 months. So that 30-year-old patient we were talking about earlier, he would still need to come in for an ultrasound every 6 months. And that's just to make sure it isn't growing or getting bigger or anything like that. All right, surgical intervention may occur earlier in 1. A rapidly expanding aneurysm, 2. Symptomatic patients, or 3. A high rupture risk patient. Surgical therapy. If it's ruptured, then emergency surgical intervention is required. Pre-op. Before the operation, what's important is hydration. They're probably going to lose a lot of blood, and they probably have been losing a lot of blood. This is a major surgery, so you're going to really want to make sure that this patient is hydrated, okay? before the surgery, because we're going to be going in there and cutting this patient up, and this is a major blood vessel. So you really want to make sure that this patient is hydrated. And you're going to stabilize the electrolytes uh, and make sure they're coagulating right and they got a good hematocrit, ideally. Unless this is an emergency situation where like the blood vessel ruptured, in which case you would just rush this patient to the operating room, okay? As fast as you can. Well, first you would tell the doctor and then rush him to the operating room. Okay, so in the surgery, they're gonna basically cut them open and fix that thing. And this is what it's gonna look like. And this is a video on that surgery if you want to learn more about it. Okay, so there's different kinds of procedures. There's an open procedure and there's an endovascular graft procedure. And the open procedure is more, well, open, and it's more uh, it comes with greater risks, but it leaves a nice and perfect and nice and neat uh, um, blood vessel. It fixes up the aneurysm perfectly. All right, so it requires cross-clamping of the aorta and proximal and distal aneurysm. As you can see here, this is clamped, and this is clamped, and then they cut them open. They put in that little thing, and then they stitch them up, and that you can see in the video as well. All right, vessel clamping is going to affect basically all this circulation to the major organs, basically like the kidneys and the bowels. Okay, so post-op, you're gonna assess the neural status, like the mentation, the vision, the speech, the motor strength. You're gonna assess for any abdominal pain and bloody diarrhea, because bloody diarrhea is a telltale sign of ischemic bowels. You also need to know that the surgery comes with the risk for spinal cord ischemia, aka leading to paraplegia, which is really bad, and renal insufficiency, which is important because without the kidneys, you can't metabolize any of the drugs that we are giving them. Okay, alright, so that's what I wanted you to know about the open surgical procedure. With regards to the endovascular graft procedure, you need to know that it's an alternative to conventional surgical repair. It involves placement of sutureless aortic graft into abdominal aorta inside the aneurysm. So they don't actually fix the aneurysm, in that they don't just remove the aneurysm. What they do is just they stick a little stent in there, and they hope for the best and hope that, the blood isn't just going to start sliding past this little thing that we put in there and start filling up the little balloon again and causing another rupture. That's pretty much it. All right, so it involves the placement of a sutureless. Okay, I already read that. It's done through the femoral or iliac artery, and here's some extra book info that I got. You can't do it if there's abdominal or iliac. If the abdominal or iliac arteries are blocked or they're too small, since the device won't be able to get through, and that's just more so common sense stuff. And here's some examples, like when the blood vessels are tortuous, small, calcified, or they're filled with thrombi. You won't be able to stick the needle in to inflate that thing, to pass that thing into. All right, the benefits of this is you're going to be under less anesthesia and operative time. There's a smaller blood loss, less morbidity and mortality, more rapid resumption of physical activity, shortened hospital stay, quicker recovery, higher patient satisfaction, and reduction in overall cost. But here's some complications. You can get an endo leak, which is basically when the blood leaks past this little endo thing that we put in there and goes straight back into the aneurysm and leads to a pop. The aneurysm can grow because of what I just explained. It can rupture again, because of what I explained. Bleeding, the graft can get dislocated and can cause an embolization, can cause a thrombus. It can, the incision site can cause an hematoma or an infection, though honestly, you would probably be at greater risk for infection in an open procedure, an open surgical procedure, but just throwing that out there that you are still at risk for an infection or an hematoma. And of course, impotence. And that has to do with the fact that, um, if they end up messing with your nerves while they're in there. All right, assessment. You're gonna monitor for indications of a rupture. This is what the most important thing that I would like you to take out of this assessment section. The signs and symptoms of a rupture, because this is a medical emergency and you as the nurse are going to be with this patient, this aneurysm patient, and you need to be able to spot these signs and symptoms of a rupture because it's a life-threatening condition and you need to do some immediate action. You need to immediately report this to the doctor so they can do an immediate life-saving surgery, okay? So an easy way to remember the signs and symptoms of a rupture is to just think of low blood pressure and shock, because basically what's happening is the patient is bottoming out because a ruptured aortic aneurysm leads to rapid and massive bleeding. In fact, like we said before, most patients don't make it to the hospital in time and they end up dying. So these are the specific signs and symptoms that you're going to see. They're going to be sweating, diaphoresis, they're going to be pale, they're going to be weak, they're going to be tachycardic, and that's because the body's trying to compensate for the sharp decrease in blood pressure. They're going to have hypotension, low blood pressure, obviously, the patient's bottoming out. They're going to have pain, abdominal, back, groin, or preumbilical pain, and this can be persistent or intermittent. And if they have pain in the left or right, it's a renal in origin, and if it's along the midline, then it's the main artery that's fucked up. That's just a fun fact that I just wanted to add in there. A decreasing hematocrit because there's a giant tear in the main artery. And there's going to be changes in the level of consciousness, and that's because the brain isn't getting enough oxygen. And you're going to have a pulsating abdominal mass. If it's ruptured, you need to call the doctor as soon as possible, because the doctor needs to perform emergency life-saving surgery immediately. And here's some extra book info that I got. Rupture into the peritoneal cavity is rapidly fatal. It can result in hematomas in the scrotum, perineum, flank, or penis. All right, so if there's a rupture in the vena cava, they're going to have signs of heart failure, and I really want you to remember that, okay? Really, really, really want you to remember that. Okay? So basically, they're going to have signs and symptoms of congestive heart failure. And that's kind of like what we talked about earlier with with this aneurysm. Like, see, these are also, I don't know if you noticed this, but just connecting the dots here, that distended neck veins is also a sign or symptom of heart failure. So I don't know if you remembered that, but I wanted you to tie the dots here. And yeah, they're going to have signs or symptoms of heart failure. So you need to know that, okay? And basically, there's pressure on the inferior vena cava, and that causes backflow into the heart. And that's why this patient's getting heart failure symptoms, because they are having heart failure. And if they are having heart failure, then they're definitely going to perform surgery on this patient. And here is, and also a loud bruit or whooshing sound will be heard. And here's some, a reminder of what heart failure looks like. Basically, edema. Remember edema. Interventions, pre-op teaching, expectations after surgery. Tell them they're going to be in the recovery room with a bunch of tubes and drains coming out of them. For example, the lumbar spinal drain, which is used to decrease the chances of paraplegia, or the cerebrospinal fluid drain, which improves spinal perfusion. Tell them they're going to be in the ICU. With regards to post-op, we're going to be monitoring them in the ICU. We're going to be looking at their arterial line, their CVP or the PA catheters. We're going to be checking the mechanical ventilation and making sure that the settings are right and that there's no alarms ringing or anything like that. We're going to be monitoring their NG tube, their urinary catheter, and we're going to be watching for signs of dehydration, like decreased skin turgor, etc., etc. Implementation, post-op. During surgery, this is just a little note that I wanted to add. During surgery, blood vessels are clamped, as you saw in the picture before. Here, see the blood vessels are being clamped here. So, what you need to know is that a great concern is that the blood vessels were clamped for so long during surgery that it has caused important tissues to die, like the bowels, leading to ischemic bowels, or the kidneys, leading to acute renal failure, or the spinal cord, leading to paraplegia or neuropathy, etc. Okay? And men can become impotent. So, we as the nurses need to watch out for the signs and symptoms of ischemic bowels or acute renal failure or paraplegia or neuropathy. All right, so with regards to infection, we're going to be giving them their antibiotics to prevent infection. We're going to assess the body temperature to make sure they're not suddenly having a fever, which would be a sign of infection. We're going to be monitoring the WBCs. We're going to make sure they get adequate nutrition, and we're going to observe the surgical incision for signs of infection like pus or drainage or anything like that. All right, implementation continued, post-op continued. We're going to be checking their GI status. We're going to record the amount and character of any NG tube output. We're going to do an abdominal assessment. We're going to make sure that they're farting, basically, because that's a sign of return of bowel function. And in fact, we're not going to let these guys go home until they fart, okay? So we really want to be looking for those farts. Really pay attention to your patient's farts. We must have farts before they leave. All right, so we're going to be assessing for signs of bowel ischemia, and this is important to know because you don't want to be sending these guys home if they have dead bowels, okay? So a sign of dead bowels would be bright red stools because the body is sloughing off the first layer of dead tissue. And here's a picture of that, so you could be traumatized forever and to forever remember that. Look at this. Look at all this gooey nastiness. That is blood, and that is coming from your butthole. And that is bad. That is a very, very bad sign. Okay? Okay, after surgery specifically. Okay, so hypo or hyperactive bowel sounds can be heard when you auscultate the abdomen. Because remember, you're going to be doing abdominal, assessments, as we said here. And usually, though, we're just going to be getting hyperactive bowel sounds if there is a problem. So, and the reason I said hypo or hyper is because it depends on the size of the ischemic bowel. So here's the explanation on that. If it's a small portion of your intestine that died, you'll get hyperactive bowel sounds, and that's because the part of your GI tract that does work will notice the tissue death and try to force or push past the ischemic tissue, which is why you get hyperactive bowel sounds. However, if it's an entire segment, like the whole goddamn transverse colon that's dead, then you won't get any hyperactive vowel sounds. In fact, you'll get hypoactive vowel sounds. So you won't be hearing much at all when you auscultate the abdomen. However, thankfully, very rarely do you get hypoactive vowel sounds because the surgeon very rarely screws up that badly. Usually, it's just hyperactive vowel sounds because it's a small portion of the intestine that died. But the main takeaway is bloating and hypo or hyperactive bowel sound is a bad sign post-op for these patients who just got out of surgery from fixing their aneurysm. All right, so we're going to be assessing their neuro status as well. We're going to be checking their level of consciousness, their pupil size, and their response to light, facial symmetry, speech, ability to move, upper extremities, the quality of their hand grasps, and we're going to keep the post-op, we're going to keep the cerebrospinal fluid pressure between 10 to 15 millimeters of Hg. And we're going to try to keep that blood pressure up to increase perfusion to all the vital organs. So ideally, you'll have the blood pressure 20 millimeters of Hg of mercury above the patient's normal baseline. And this is something that the professor stressed like a million times. He said the MAP should be greater than 90 millimeters of mercury for the first 2 days post-op. So really focus on memorizing this. The reason he stressed this is because MAP is a better indicator of tissue perfusion than the systolic blood pressure. Okay? So we want that MAP to be greater than 90. Just greater than 90 for the first 2 days post-op. Remember that. Stick it in your head. Forever remember that. If there's a question on the exam, you better get it right, okay? Above 90 for MAP. First 2 days post-op. Remember. Okay. The reason we try to do this is the reason we keep that blood pressure up is because it decreases the chances of paraplegia, because it increases the perfusion to your spinal cord. All right, so peripheral perfusion status. Basically, you're going to be doing a pulse assessment. You're going to mark the pulse locations with a felt tip pen, ideally before the surgery, and then after the surgery, you're going to go back to those little X marks and see if you can feel the pulses again. And you're going to continue to feel those pulses. And if suddenly you can't feel the pulses anymore after the surgery, then that's a bad sign. That means that those limbs are not getting circulation. Probably there's a problem after surgery and you need to figure out what's going on. All right, also you're going to check the extremities for temperature, color, capillary refill, sensation, and movement. And that's just basically to be checking for cyanosis or, yeah, basically. And you're going to be watching out for signs of hemorrhaging. Okay, so if suddenly the H&H is dropping and the blood pressure is dropping and they're getting tachycardic, then that's a bad sign. That means they're bleeding out. All right, you're going to be checking their renal perfusion status. You can remember what I said earlier, and we can see here conveniently. They clamped these parts, and the major concern is that they clamped them for so long that the major organs died, like the kidneys. Maybe the kidneys died during the surgery. So you're gonna have to watch the urine output, make sure they're peeing, and check their fluid intake. If they're not peeing, is it because they're not getting any fluids? You're going to be checking their daily weights to see any sharp increases or decreases. You're going to be checking the CVP or PA pressure. You're going to be checking the blood urea nitrogen or creatine levels. And here's some extra notes that I got from the book under other aneurysms with regards to endovascular repair in particular. And remember, endovascular repair is the non-invasive one, where they just stick a needle in there and thread that, uh, thing in there, this metal thing in there. Okay, so the patient's going to lie supine for 6 hours post-op, and then after those 6 hours, they can roll around, maybe, if they can tolerate, and maybe they'll be able to ambulate with assist to the bathroom. All right, so the head of the bed may be elevated 45 degrees after 2 hours. After this specifically. So they lie in the supine for 6 hours, and then head of the bed may be elevated after 2 hours. Vital signs and Doppler every 15 minutes, and then at progressively longer intervals if the patient's status remains stable. Check the access site while you're there. Check it for bleeding, pulsation, swelling, pain, or hematoma formation. Basically any problems that are going on there, or signs of infection or anything like that. And you're going to use a bedpan or a urinal while they're on bed rest. And if they can't tolerate ambulating to the bathroom with assist. You're going to look for problems. And I put this in red because these are major problems. So signs of embolization in the lower extremities, like extremely tender or irregular shaped or cyanotic areas. Okay, vital sign changes or changes in the pulse quality, any bleeding or swelling or pain or hematomas. You need to report these problems immediately to the doctor, which is why I put these in red. All right, you're also going to look for potential problems like a persistent coughing, sneezing, vomiting, or systolic blood pressure that's greater than 180 millimeters of mercury. You're going to report these to the doctor. Why? Because it can cause the patient to hemorrhage. They can open up their sutures. All right. You're also going to monitor their temperature every 4 hours, and that's to check for signs of infection. You're also going to check for signs of post-implantation syndrome. And if you do see signs of that, you're going to report it. Well, what is post-implantation syndrome? Well, this is a syndrome that occurs within the first day of the stent graft placement, and the symptoms occur suddenly. They'll suddenly get a fever, an increase in white blood cells, and thrombocytopenia that is transient. Management for this condition, for this post-implantation syndrome, is going to be mild analgesics like Tylenol and some anti-inflammatory agents like ibuprofen. And it's usually going to go away in a week. Diet. Most patients can resume their diet. You're going to encourage them to drink fluids, and IV infusion is going to be continued until the patient can drink normally. Discharge teaching. Encourage the patient to express their concerns. Instruct the patient to gradually increase activities, but tell them to avoid any heavy lifting, because then they're just going to open up their sutures again, and that's going to be a big problem, which is why I emphasized this and put it in red. Educate on signs and symptoms of complications like infections or neurovascular changes. All right, and that's basically the main thing that we're going to be tested on. These are minor things that we're not really going to be tested on, but I wanted to expose you to in case they do throw out a question on that. But mainly the main bulk of the readings was abdominal aortic aneurysms and thoracic aortic aneurysms, and comparing and contrasting the two, and the nursing interventions for all of that. But let's go into it. Dissecting aorta. It's a tear in the aortic intima that creates a false lumen through the aortic media, and they discussed that a little in the nucleus media video that I posted at the beginning of this of these notes. It's one of these two. So if you look at that, you'll be able to see what it looks like. It's a tear in the lining, in the intimal lining, and it allows blood to track between the intima and the media. It's also misnamed as a dissecting aneurysm. It's associated with atherosclerosis, male gender, poorly controlled hypertension, and blunt force chest trauma, and cocaine use, because cocaine increases your blood pressure and puts a lot of pressure on those blood vessels. All right. So, they most commonly occur in the aortic arch, and they may progress to the heart, and that's something that we discussed here. Conveniently, it's right here. Or actually, no, it's up here. Here. When we were talking about the thoracic ones, the thoracic aneurysms, we discussed that the dissecting aneurysm most commonly occurs in the thoracic region. All right, that's just how the book formatted it, but now that I think about it, I should have just removed that and just kept it right there in the under dissecting aortas, but oh wells, too late now. So just wanted you to know that it most often occurs in the aortic arch in the thoracic region. As the heart contracts, each systolic pulsation increases the pressure on the damaged area, and that further increases the dissection, and then it may occlude the major branches of the aorta, and that's going to cut off blood supply to the brain, abdominal organs, kidneys, spinal cord, and extremities. Clinical manifestations. It's going to depend on the location of the intimal tear and the extent of the dissection. They can have some sudden severe pain in the anterior part of the chest or the back, radiating down to the epigastric or abdomen. It can be described as a tearing or ripping sensation. And I guess that's the main thing that I would take out of this. It can mimic a myocardial infarction, and the blood pressure may be markedly different from one arm to the other. All right, because of the subclavian artery. Diagnostic studies, X-rays, CT scans, transesophageal echocardiography, MRIs, management, medical therapy. If no symptoms, pain relief and blood pressure control. Surgical therapy, emergency surgery for acute ascending aortic dissection, or when drug therapy is ineffective or complications of aortic dissection are present. Usually we do an endovascular dissection repair, which is similar to EVAR, which is what we discussed, the one that is not invasive, this one. Okay. Okay, pre-op management, bed rest, maintaining a quiet environment, anxiety and pain meds, continuous IV administration of antihypertensive agents, continuous ECG and intra-arterial pressure monitoring, observation of changes in quality of peripheral pulses, frequent vital signs, and here's some extra book stuff that I got from the book. Systolic blood pressure is maintained at approximately 90 to 120. MAP is 65 to 75. And this is with regards to pre-op and specifically to dissecting aneurysms. So I don't want you to get this confused with the post-op for the aneurysms, for the thoracic and abdominal aneurysms, because for those you want them to be high. You want the MAP to be high. You want the MAP to be above 90. So we're talking about something different here, and I want you to separate the two, okay? So we're talking about pre-op for dissecting aortas, okay? So you're going to keep the map between 65 to 75. You're going to use beta blockers, diuretics, ACE inhibitors, and angiotensin 2 receptor antagonists, calcium channel blockers, and you're going to choose sodium nitroprusside in emergencies because they decrease the blood pressure really quickly, and they get out of the body really quickly. This drug, the sodium nitroprusside. Okay, so surgical repair, but this is just a note that you added, Evelyn. Okay, so I forgot to remove that before I published these notes, but whatever. Okay, so, all right, post-op, discussed earlier. Discharge teaching, therapeutic regimen, antihypertensive drugs, and side effects. If pain returns or symptoms progress, instruct patient to seek immediate help. A result of atherosclerosis, involve renal, tell them that it's a result of atherosclerosis. Involve renal artery, femoral artery, or popliteal artery, most commonly, and tell them that this symptoms are pain, swelling, or pulsating lump. The diagnostics are ultrasound, CT scans, and arteriographies. Okay, so cerebral aneurysms, you're not really going to be tested on that. So that's why I put it in Tiny's text. And we're going to go into more depth later on in the semester with regards to this. Okay, so that ends my lecture.